And greetings from the Institute of Liver and Biliary Sciences. I am Dr. Rajeev Khanna from the Department of Pediatric Hepatology. So I am giving this talk on variceal bleed in a child endoscopic pulse. I would like to thank organizers for giving me this opportunity to speak for this midterm Endocon 2021. So there is nothing to disclose. So I will give my talk under these headings. So what are the differences from adults? So there are etiological differences. So as we see from the data from the West that the etiology of portal hypertension is primarily cirrhotic, that is biliary atresia, autoimmune hepatitis, cystic fibrosis, alpha-1 antitrypsin deficiency. But from our Indian subcontinent, the predominant cause of portal hypertension from the older series have been reported as extrahepatic portal venous obstruction, followed by cirrhosis. But this may be a referral bias, and also in the older studies, the upper GI endoscopy was not done in all the cirrhotics. So in the non-cirrhotics, there are 6 times more risk of variceal bleed in comparison to cirrhotics, and this bleed rate is particularly related to splenomegaly and platelets in non-cirrhotics, whereas in cirrhotics, it is related to splenomegaly or presence of ascites. So this is our institute protocol to evaluate children with portal hypertension. Those who present with variceal bleed with splenomegaly or CLD with splenomegaly or evidence of thrombocytopenia, we look for evidence of CLD, and also we look for whether with a variceal bleed, whether the bleed is tolerated well or not. Intolerance means if there is development of ascites, encephalopathy, jaundice, or coagulopathy, and if the answer is yes, then this is cirrhotic portal hypertension. The common causes being biliary atresia, PFIC, autoimmune hepatitis, HVOTO, or Wilson disease. And if there is no evidence of CLD, then this is non-cirrhotic portal hypertension, which can be confirmed as EHPV on Doppler. And if there is no cavernoma, then then the possibilities are congenital hepatic fibrosis or non-cirrhotic portal fibrosis. So what is the importance? So as per this series from Canada, so this study has shown that the cirrhotic children, when they bleed, so there is development of ascites, infection, respiratory complications, acute kidney injury, and encephalopathy, similar to that in adults. And we have also seen in our cohort, which is still unpublished, this is 135 variceal bleeders. The etiological subset was cirrhotic in 79 and EHPV in 46. And this is the breakup of the cirrhotic children. The common etiologies are biliary atresia and autoimmune liver disease. And we further analyzed 101 variceal bleeding episodes in 79 cirrhotic children, where the median age at bleed was around 84 months, and the median bleeding episodes were ranging from 1 to 8. And of these 101 bleeding episodes, 70 had decomposition and 5 had acute or chronic liver failure, and the median PELD score was 13. So our protocol is to do EVL whenever it is feasible, and to follow up these children every 3 to 4 weeks. And then when the viruses are non-bendable, we take these children for EST every 3 to 4 weeks till variceal eradication in younger infants. Under 2 years of age, we do EST alone till the viruses are eradicated. And of these bleeding episodes, transfusion requirement was present in 70%. 16% of these bleeding episodes were tolerated well. However, there was rebleed in 31 of these children at a median of around 36 weeks. 4 of these bleeds were uncontrolled, which required intervention radiology procedures. And similar to the adults, there was increase in ascites, and 79% of these children, 52% had encephalopathy, 18% had acute kidney injury, and 12% had pneumonia. So overall organ failures, if we see, more than around 50% of these children had more than equal to 4 organ failures, and these organ failures actually determined their outcome. Of these 101 variceal bleed episodes, 80 children survived with native liver, and 12 patients died at a median of 32 days, whereas 9 underwent liver transplantation. So the predictors of death, when we analyzed them on logistic regression analysis, it was found that presence of hepatopulmonary syndrome and pediatric CLIF-SOFA score was associated with mortality at day 90. So thus, we knew what is the importance of variceal bleed. Now we'll discuss briefly about the special scenario of biliary atresia, which is the commonest pediatric hepatology hepatology disease. So if we look up the long-term outcome of a successful Kasai potrantostomy in biliary atresia, so what is the natural history? So variceal bleed is an important event in this natural history. And if we look up series on portal hypertension and bleed in biliary atresia, the green one shows the shorter follow-up of up to 2 years in unsuccessful Kasai. Here we can see that varices portal hypertension was present in up to 90% of these children, and bleed rates are 20 to 34%, whereas in the longer follow-up, beyond 10 to 20 years, again, the portal hypertension was present in around 50% of these children with bleeding rates ranging from 20 to 32%. Again, from the long-term series, 5 to 25 years, post-Kasai potrantostomy, portal hypertension is an important component up to 95%, and cirrhosis is almost universal. Again, from this series, from the East, so this has shown that uncontrolled variceal bleed and portal hypertension is an important indication for liver transplantation in anectic biliary atresia children. So the variceal bleed risk in biliary atresia is related to the grade of the esophageal varices, presence of gastric varices, and also the red color signs. So more the gastric varices and red color sign, there is more risk of bleeding. And also, when the bilirubin is more than 100 micromole, or that is more than 6 milligram per deciliter in a biliary atresia child, or if the initial endoscopy showed higher grade of varices, there is more progression to high risk varices with more likelihood of bleeding. So what happens after the bleeding? So when the bilirubin is more than 4 milligram per deciliter in a child who had variceal bleed, so there is 50% survival at 1 year. And if the bilirubin is more than 10 milligram per deciliter, that there is 50% survival at 4 months with an odds ratio of mortality of 12. So now coming to what precautions we should take while performing endoscopy. So in an extrahepatic portal venous obstruction, which is one of the commonest variceal bleed which we see in children, so the congenital anomalies should be looked for. The common ones are cardiovascular, renal, craniofacial, like cleft lip, cleft palate, Turner syndrome. And we have also seen that at our institute, 11% of these children had congenital anomalies in the form of cardiac defects, microcephaly, Dandy-Walker syndrome, Pierre-Robin sequence, and retrognathia. In biliary atresia, again, we should be aware of the major anomalies which are seen in up to 15 to 20% of these children in the form of cardiovascular, genitourinary, and gastrointestinal anomalies and splenic malformations. Antibiotic prophylaxis should be routinely given to all the cirrhotics with variceal bleed, and also for a planned band ligation or EST, where there are associated cardiac conditions known to have high poor outcome following endocarditis, or if the patient is having severe neutropenia, that is absolute neutrophil count of less than 500, and this should be covered with either with third generation cephalosporin or with piperacillin tazobactam to cover the enteric gram negatives and gram positives. General precautions pre-procedure include: we should allow the parents and guardians in the endoscopy area to allay the anxiety. Consent and assent forms should be taken. Child should be well hydrated. It should be a child-friendly atmosphere. While performing procedure, we should be aware that children have higher body surface area, so they are more prone to hypothermia. They have higher oxygen requirement, and while doing endoscopy, we should be aware of the duodenal angulation. Post-procedure, there should be appropriate space for the family and feeding, and also the monitoring apparatus should be proper. Positioning of the head and neck is important for certain patients, like high-risk patients like Down syndrome. So coming to the checklist, so this is a checklist for pediatric procedures which has been proposed by NASPGHAN in 2019. We should look for whether there is the baby is premature, difficult airway, higher BMI, cardiac disease, or if there is endocrinopathy, renal disease, or any other metabolic condition which may affect the fluid or electrolyte requirement. If there is neurological involvement in the form of hypertonia or hypotonia or seizures which can affect the sedation planning, and also the respiratory or pulmonary diseases which can again affect the sedation planning. So scope, we should be aware. So this is as per the guidelines that less than 10 kg or less than 1 year, the ultra thin scopes, that is less than 6 mm scope, should be preferred. For above 10 kg or above 1 year, standard adult gastroscope can be used. As per NASPGHAN guidelines, there is bit change. That is less than 5 kg, they recommend ultra thin, 5 to 20 kg slim adult scope, and more than 20 kg adult scope with a channel diameter from 2 mm to 2 to 2.8 mm and 2.8 mm. So here in the picture, we can see what is the difference in the size of the 5.5 mm scope and 8.8 mm scope. So the fasting recommendations as per the American Society of the Anesthetist is 4 hours for those infants who are on breast milk, whereas 6 hours for infants who are on formula or non-ML milk or solids, but clear liquids can be taken till 2 hours before the procedure. So coming to the anesthetic viewpoint, so what are anesthetists careful for? And so they are careful for the airway. Like younger infants, they have small compliant airway, which has more chances of resistance, and there is tongue fall, which is precipitated by mucus or edema, and also precipitated by usage of ketamine. In under 5 months old age infants, so we should be aware that they are obligate nasal breathers, and up to 5 to 7 years of age, there is more chances of tonsil and adenoid hypertrophy. So there is more chances of airway obstruction. Children may have hyperreactive airway, either part of the bronchial asthma, or which may be precipitated by the upper respiratory episode. So if it is an elective procedure after a bleed, so then the procedure can be delayed for a few days to few weeks. And also children are more prone to hypoxemic episodes. So these episodes are tolerated poorly, but the tolerance to fluid is better, but the fluid should be adjusted as per the weight. So for sedation and analgesia, preoperative midazolam can be given, and it is always recommended that it should be an anesthetist administered deep sedation for the endoscopy, and this is almost now standard of care for most of the pediatric endoscopy setups. At our institute, we are using a combination of propofol midazolam with or without ketamine, and for younger children, sometimes sevoflurane is also used. So children at risk for cardiopulmonary events with sedation should be carefully looked for. So like the conditions where they have compromised cardiovascular function, congenital heart defects, infants under 1 year of age with pulmonary disease, muscular disease, or with recent acute upper respiratory infection, they are more prone to sedation related events. Now coming to the airway is assessed as per the Malampati classification, but it is not validated in the pediatric age group. So as per this classification, the class 3 and class 4 airways where the uvula is either touching or uvula is not visible. So these are the candidates which are high risk for high risk for difficult intubation. So those children who have craniofacial anomalies, high arched or narrow palate, large tongue, short thick neck, or with prominent overbite, or those with Down syndrome or other syndrome, they should be looked up carefully. So there is risk of poor ventilation with pulmonary disease, and also with neurological diseases where there is risk of aspiration, like with cerebral palsy, neurological Wilson, mitochondrial disorders, Niemann-Pick, or those babies who are on anti-epileptic medications. So this is all anesthetic paraphernalia constituting the various sizes of endotracheal tubes, curved and uncurved, TPs, laryngeal mask airway, and also the laryngoscopes, various sizes, headrest, and a smaller mouth guard, and the monitoring smaller BP apparatus and the smaller pulse ox, and also the stillet and the bougie for the intubation. So now coming to the what is specific thing about young infant when a young infant comes with biliary atresia presents with variceal bleed. So a younger infant, we should be more careful about fasting, whether the patient is having hypoglycemia, how much IV fluid he is getting. The patient is prone to have a small airway and a difficult airway, and he is a nasal breather, and the ultra thin scope is indicated in these infants. So but the problem with these ultra thin scopes are the small injection needle can go inside the scope, but it is not always it is not always easy to get the small sclerotherapy needle, for these kind of scopes. And also even if you are getting this small injection needle, there may be a problem with the suction when you are injecting the varix. There may be a problem with the suctioning of the blood and the air inside the stomach. So now coming to the evidences and technique. So the esophageal varices, as we know, are classified as per the same classification as in adults. The size, number, extent, form, color, red color signs, and evidence of active bleeding is grading as grade 1 to grade 4, and also as per ASLD classification for better comparison as small varices or large varices less than or more than equal to 5 mm in diameter. Gastric varices are classified as per Salin's classification as gastroesophageal or isolated gastric varices. So these are the pictures. So the technique of the band ligation or endoscopic sclerotherapy. So for band ligation, the larger varices should be banded first. and this should be in a spiral fashion. We should be careful that two bands should not be at the same level, because this can lead to the development of stricture, and the banding should be started at least 1.5 to 3 centimeter from the gastroesophageal junction, depending on the size of the baby and the length of the esophagus. For sclerotherapy, the smaller varices should be injected first, because if you touch a larger varix with the needle, so then the whole view may be obscured by blood, and it will be difficult to inject the smaller varices. And bleeding is quite common when you are injecting, when you are doing the sclerotherapy. So with each bleeding, you have to go inside, tamponade it, and then again come back. So it takes time. And it is recommended that 0.5 to 2 ml should be injected in each of the varices, and the preferred thing is to do injection intravariceally rather than paravariceally, to block all the perforators which are draining the varices. So these are the endoscopic series in extrahepatic portal venous obstruction, where the eradication rates have been shown to be 88 to 95% with endoscopic sclerotherapy, but the recurrence rates up to 26%. So there are two randomized control trials, older series, but they are well curated, and this is the summary of these endoscopic of these two randomized control trials, where they have shown that EBL has better eradication rate, but there are more chances of new gastroesophageal varices and recurrence of varices. Variceal recurrence is more with endoscopic variceal ligation in comparison to endoscopic sclerotherapy. Number of sessions are less with EBL. So there is faster eradication with band ligation in contrast to sclerotherapy, and the rebleed rates are more with sclerotherapy, and more chances of complication with sclerotherapy in the form of stricture and ulcer formation. And if we consider the total cost, it is per session the band ligation is costly, but if we look up the total cost of considering total number of sessions, then overall sclerotherapy is costly in comparison to the band ligation. So what happens after the eradication? So there is the portal hypertensive gastropathy and gastric varices, they increase after the eradication when we use sclerotherapy. So these are the various sclerosants used. Absolute alcohol is now obsolete. So other sclerosants are sodium morphoate, sodium tetradecyl sulfate, and polydoconol, each used in liquids of 0.5 to 1 ml for each varix, with a maximum dose ranging from 5 and 3 to 5 ml. So this is the protocol which we also follow, and this was published from SGPGI, where EVL is followed by EST. So EVL till varices are non-bendable, and then EST is used. So this leads to faster cure and less complications, less recurrence of varices, and less chances of recurrence of the variceal bleed. So gastric variceal bleed is rare, up to 4% in children with overall bleeds. So it is mostly secondary, and most of the children who have gastric variceal bleed are extrahepatic portal venous obstruction, and mostly these bleeds are from isolated gastric varices. Hemostasis, this study has shown, was achieved in all of them, but gastric variceal obliteration was achieved only in 57% of the patient. There was rebleed in 4 out of 28 children, and 14 underwent shunt surgery, and 9 were awaiting shunt. So what about prophylactic endoscopic sclerotherapy? So can we do this? So there is one randomized control trial in children where the EST was compared with the controls, and those who were taken for EST, there was 20% less chance of variceal bleed over time, but with more risk of development of portal hypertensive gastropathy and a comparable survival. So, but the problem with this study was that they have taken cirrhotic as well as the non-cirrhotic portal hypertension in the same basket. So what about primary prophylactic endoscopic sclerotherapy in biliary atresia infant? This is the commonest etiology in our setup. So this study has compared primary EST with those who come with bleed and received secondary prophylactic EST, and this study has shown that those who were taken up for primary prophylactic EST have better overall survival and better transplant-free survival. So there are various issues when you are using endotherapy in biliary atresia children. As band ligation is not feasible under 2 years of age, so there is need to develop smaller band for ultra thin scopes, and prophylactic EST may need more data. And how many sessions of EST have to be done, because biliary atresia is a progressive disease. There is progressive portal hypertension, so you continue to do sclerotherapy sessions for a longer period of time, and also there is a risk of EST ulcer bleed, which will be taken in the next lecture. And also when there is recurrent bleed, so this one should understand that this is the time for the liver transplantation in biliary atresia. So this is the survey on the clinical practice of primary prophylaxis in portal hypertension from 35 French centers, where they have shown that almost all of them were using some sort of primary prophylaxis, either in the form of beta blockers or EST or EVL, but there is no generalized consensus. So there is need for research and industry inventions. So as we can understand that band ligation is not feasible for under 2 years of age or under 10 kg weight. So prophylactic EST, we need more data, more research, and also small banding apparatus is required for younger infants with biliary atresia. But what is the feasibility and what are the cost implications? We don't know. And what is the ideal age for variceal screening in children? So this should be etiology based. So thus finally, to conclude, I can say that extrahepatic portal venous obstruction and biliary atresia are the commonest causes of variceal bleed in children. So cirrhotic children, when they bleed, there is a risk of organ failure, but this risk is less than adults. Most episodes are well controlled with timely endotherapy. So special precautions and checklist is required for younger children, and there is need for further innovations for younger children with biliary atresia. Thank you.
I presently work as head of the Department of Gastroenterology and Pathology at PSG Institute of Medical Science and Research. I did my MBBS and MD from Stanley Medical College, Chennai. I did worked as a registrar in gastroenterology at PVS Memorial Hospital, Cochin, and then later I did my DM gastroenterology from Christian Medical College Hospital, Vellore. Subsequently, I joined in 1999 at PSG Institute of Medical Sciences, and I've been currently working in the same institute for the last 22 years. I had now I presently head the Department of Gastroenterology and Hepatology at PSG Institute of Medical Sciences, Coimbatore. Good morning. I am thankful for the organizing committee for having Dr. Manoj Kumar Sahu and Dr. Avinash for having given me this opportunity to speak on the subject post-esophageal variceal band ligation ulcer bleed. Introducing the topic, endoscopy is paramount in the management of patients with liver disease and esophageal varices caused by portal hypertension. Varices can occur in 50% of patients with cirrhosis. Even with well-documented and improved endoscopic techniques and treatments of variceal bleed, the mortality in variceal reaches at least 20% in 6 weeks in variceal bleed. And endoscopic variceal ligation has been recommended as the best treatment for obtaining hemostasis in acute bleeding. Furthermore, endoscopic variceal ligation is also performed as prophylaxis of recurrent bleeding even before the first episode, and when the patient is also insensitive to beta blockers. After endoscopic variceal ligations, complications can occur such as heartburn, chest pain, transient dysphagia, odynophagia, stricture formation, worsening of postal gastropathy, and there is a significant amount of patients who are in child C who can develop bacteremia after post-variceal ligation. But the most significant complication which we are interested is rebleeding after endoscopic variceal ligation. This rebleeding may be caused by a post-EVL band ulcer which can occur 3 to 7 days after endoscopic variceal ligation or a second episode of variceal hemorrhage. What is more significant in this is that even though the post-ulcer ligation bleed is about 3.6%, varying from 3.6% to 11%, the mortality of this is very high. It ranges anywhere between 13.5 to 52%. It is important that post-banding ulcer hemorrhage must be suspected in a patient who has undergone endoscopic variceal ligation, especially when he presents with hematemesis, hematochezia, melena, or anemia after EVL, especially within 2 weeks after endoscopic variceal ligation. Once we identify a post-EVL bleed, measures to re-establish hemodynamic parameters must be taken to prepare the patient for a new upper GI endoscopy. There are also different therapies now which can be adopted to control or even avoid this type of hemorrhage. What is the epidemiology? Most of the prior studies on complications following EVL, the global rate of rebleeding is about 15% within 5 days. There are also incidences which can happen 3.6 to 11% in many of the studies. I should confess, most of these studies are case control studies and anecdotal studies. The mortality in a post-ulcer bleed has been recorded as high as 13.5 to 52% in the first 5 days, and it reaches anywhere between 14% to 20% within 6 weeks after the post-EVL ulcer bleed. Rebleeding after EVL can be caused by either variceal hemorrhage or EVL ulcer. American Society of Gastroenterology, in its recent update on endoscopic management of variceal bleed, has pegged at 3.6% as the percentage of bleeding due to post-EVL alert, irrespective of prior indication. It could be a primary prophylaxis or a secondary prophylaxis or during an active bleed. It is also to be noted in majority of the studies that the rebleeding occurs frequently in an emergency ligation than an elective ligation. And it has also been shown that in an elective ligation, when your number of bands go beyond 6, there is an increased incidence of post-EVL ulcer bleed. The mortality, as I told you in the first 5 days, has been documented at anywhere between 13.5 to 52%. Another major point of mortality in majority of the studies has been the bacterial infections as a major complications which increase the mortality in post-EVL ulcer bleed. The bacterial infection has been pegged at 18.5 to 27%. And in some of the patients whom we had the 5-day mortality, liver cell failure, sepsis, and a spontaneous bacterial peritonitis have been recorded as prominent features of mortality in these patients. It has been shown that even if an active bleed of a variceal bleed is treated with pharmacotherapy, endoscopic treatment, which could include variceal ligation and antibiotics, a 5-day failure of 10 to 20% has been documented. And this has been very well shown by the Barcelona group in 2016. So what are the risk factors for a post-EVL ulcer bleed? There are at least about 5 to 7 studies which has been shown to have done a case control study or retrospective studies in patients who have come with post-EVL ulcer bleed. Few studies have shown, majority of the studies have shown that a patient with Child-Pugh C class has got a major risk of rebleeding. A higher MEL score or a higher MEL sodium score of more than 24 has shown to have an increased risk of rebleeding. And it has also been shown that if you have a higher MEL sodium of more than 24, the mortality could anywhere between 39 to 40%. And if a patient has got a documented spurter of a bleed in post-EVL ulcer with a high MEL score, the mortality is close to 39%. Some of the studies, especially the study from France, have shown an associated high APRI index, which shows associated increased fibrosis, the presence of peptic esophagitis, and a low prothrombin index has increase of bleeding. These three things, peptic esophagitis, low prothrombin, high APRI index, has been documented only in one French study from NIS, and other studies, including our study from ILBS, have not shown this as a significant risk features. It has been shown that coagulation status does not predict rebleeding after EVL. This is a study from Stephen Calver, where they looked at 141 patients who had a post-EVL ulcer bleed, and they were subjected to prothrombin time. They are subjected to protein C and protein C estimation. They are subjected to D-dimer levels, subjected to fibrinogen levels, and they also underwent thromboelastography. And there is no difference between the patients who bled and patients who are not bled. So it is not very clear whether patients who come with a rebleed should we routinely treat them with coagulation products. This is a study which I was referring by Stephen Calvert, where 49% of child A, 28 child B, and child C underwent primary and secondary prophylaxis, and they were all assessed for these factors, and the parameters did not differ between the bleeding and other patients. The other risk factor, which has been shown in a study from Hospital de Medwiz from Spain, a presence of portal vein thrombosis with or without HCC has an increased risk of bleeding. This study showed that apart from a MEL score, the presence of portal vein thrombosis and presence of hepatocellular carcinoma were significant risk factors for rebleed. In fact, in this particular study from the Barcelona, Spain, from the Hospital de Medwiz, showed that presence of HCC had an 8 times higher risk of rebleed after post-EVL ulcer. And it has been shown that the mortality in the presence of HCC is close to about 39% in these patients. About the number of rubber bands applied, it has been shown that the post-bleed ulcer is more common in emergency ligation procedures rather than elective ligation procedures. And normally in an emergency procedure, there is a tendency to put number of bands. And if the bands exceeds more than 4.9 or more than 6 bands, it has been shown that there is increased risk of rebleeding. In a Mayo Clinic study, it has been shown that if you can have an interbanding interval of more than 3 weeks, the risk of ulcer bleed is much less when the interbanding interval is less than 2 weeks. In a patient who had a rebleeding, a study from Dr. Miranda's group from Spain has shown an endoscopic ultrasound evidence of a large paraesophageal varices when they are present shows that the rebleeding rate is very high. So the risk factors could be child C, a higher MELD, portal vein thrombosis, HCC, emergency ligation, increased number of bands, an interbanding interval less than 3 weeks, and presence of large paraesophageal varices are the common risk factors which have been documented in some of these case control and retrospective studies. There is no evidence except in one study to show that the coagulation status has some impact on post-ulcer EVL bleed. The management could be of 2 modalities. One, can we have prophylaxis of preventing post-EVL ulcer bleed? Number 2, when they present with a post-ulcer bleed, what are the options of management? Let us look at the post-prophylaxis of ulcer bleeding. There were quite a few drugs which were implicated or tried in preventing post-EVL ulcer bleeding. One of this has been larger studies, has been role of PPI. There are at least 5 studies which we have seen, which I could see, starting from 2005, 2013, 2015 and 2017, looking at the role of proton pump inhibitors in patients with cirrhotics who have undergone a post-variceal ligation. Most of these patients have received an IV pantoprazole for 5 days after post-variceal bleed and more than 4 to 6 weeks of proton pump inhibitors orally in these patients. It has been shown that PPI decreased the post-band ulcer size. It also decreased the risk of treatment failure after EVL. It shows that PPI can reduce the width and number of the post-EVL ulcers. There is one controversial statement saying that reduce the rebleeding rate after PPI and oral therapy, but other studies have not shown any benefit in or impact of PPI on the rate of rebleeding or mortality after rebleeding. At the same time, we should have concerns of PPI in a cirrhotic patient. The PPIs are known to increase the bacterial infections in patients with PPI, and especially if they are having ascites where incidence of spontaneous bacterial peritonitis is high. Most of the cirrhotic patients have a low acid output. So putting them on a PPI will increase the bacterial translocation, bacterial infections. And it has been shown that PPIs are generally required in a lower dose in cirrhotics because most of them are metabolized by the CYP2-450 metabolism in the liver. So this is one concern where the patients with PPI in cirrhotic, we need to take into consideration despite the fact there are quite a few studies which shows that there has been some benefit, and it can be a useful recommendation to put the patients on post-EVL status on a PPI. There were studies on sucralfate after EV ulcers, which shows enhances the recovery, but again, there was no incidence of decreased rebleeding because of sucralfate. What is the role of non-selective beta blockers in preventing bleed? The study which came up which is still in the press in 2020 from the Hospital Belvedere group from Barcelona has shown that patients who had a rebleed had a lower dose of beta blockers during the post-EVL period. And it's been shown that when you give EVL plus Nadolol, they seem to have much better response rate or less treatment failure when you combine ligation with beta blockers versus ligation alone. And in this particular study, they've shown that if these patients have received a reduced dose of beta blockers, there was increased incidence of rebleed even up to 6 weeks. Simvastatin, somatostatin octreotide has been studied after post-EVL as a prophylaxis, but somatostatin and octreotide are not recommended as a prophylaxis to prevent re-ulcer bleed. In fact, when you give vasoconstrictors versus PPI, there was one study which showed that the vasoconstrictors had more post-EVL ulcer bleed rather than a PPI in these patients. So as a prophylaxis, there are studies with simvastatin which reduces the portal hypertension, but it has not been documented to prevent rebleeding or decrease the mortality in these patients. How do you diagnose post-EVL ulcer bleed? Any patient who has undergone a post-EVL ulcer ligation, if he comes with hematemesis, hematochezia, melena, or anemia within 2 weeks, need to be considered for a post-EVL ulcer bleed. And it is important that we rule out non-variceal bleeds, variceal ulcer bleeds, like the presence of duphalois, presence of a peptic ulcer, presence of severe portal gastropathy. And in one study from ILBS, which was published in 2000 by Dr. Kapil Jamwal, they have now diagnosed post-EVL ulcers by an endoscopic appearance. And they have classified these ulcers as type A, ulcer with spurting, type B, ulcer with ooze, type C, ulcer with clot or pigmented base, and D is ulcer with a clean base. It has got certainly a prognostic implication, as shown by the study, that the patients with A or B had a higher mortality, and we need to consider different type of therapy to prevent ulcer from these patients apart from an endoscopic therapy. And this paper has come from the ILBS, which shown that they have classified these ulcers as 4 types. This is a patient who had a banding and an ulcer, and you can see an ulcer spurter which is coming from there, and you can see on the left hand corner an ulcer with a ooze. You can see an ulcer with a clot, and this is an ulcer with a clean base. It is also shown that patients with ulcer A and B, that is with a spurter and bleed, had a higher 5-day mortality when compared to ulcer with a clot or ulcer with a ooze. I'm sorry for this slide. This slide needs to be slightly bigger. This is a multivariable analysis from the ILBS group, where according to them, when they looked at it, 141 patients who had a post-EVL ulcer bleed, they looked at patients with ulcer type A and type B had a higher mortality, and they had a higher mortality in the first 5-day mortality. And what really showed them the indicators of mortality is higher MELD sodium score, a higher CTP score, and a type A or type B ulcer in the group, which showed higher mortality of post-EVL ulcer bleed. This is another study which came from NIS, which showed that when you compared with the controls, patients with previous treated blockers, previous variceal bleed, and if they received lesser beta blockers, had higher risk of bleeding in these patients. It has also been shown in the study that if you are not able to bring down the HVPG in a post-EVR ulcer bleed, and if the HVPG is more than 20, you have increasing treatment failure, increase in mortality. This study, where they used terlipressin, and after 48 hours of terlipressin in post-EVR ulcer ligation, when we are able to, they were able to reduce the HVPG, the mortality or the treatment failure comes down. But if it is high, this thing. So it is important, the thing. Not many studies have done HVPG. Barcelona group has done, and ILBS has done in 18 of their patients. So how do we manage these patients? So when a patient presents with a hematemesis, hematochezia, melena, or an anemia, we need to identify this as a post-EVR bleed. We don't have a clear-cut guidelines how do we manage this patient, and the best strategy still remains undefined, because many of these patients, many of these studies have shown different protocols in different groups. Clinical management must be implemented before endoscopy. That means if the patient has got an exsanguinating bleed, he has to have an airway protection. He should have adequate intravenous lines. And just like an acute variceal bleed, we need to follow the restrictive blood transfusion strategy and maintain the hemoglobin concentration 7 to 8 unless the patient has got a coronary artery disease. We still don't have a data whether FFP or platelets have to be given, except by one group from France, which they said they regularly give if the prothrombin index is low or the platelet count is less than 50. Prophylactic antibiotics, either by IV ceftriaxone, needs to be given to these patients. And if the patient has come with a post-ulcer bleed, there are indications that terlipressin, octreotide, or somatostatin may be useful. And we need to plan an endoscopy, probably an early endoscopy within 12 hours, have shown to benefit these patients with higher survival. The management could include endoscopy. What is the endoscopic methods we can have? We can, the patients can have an early endoscopy and have a new ligation of the bands below the ulcer, or if there's a spurting over the spurting ulcer. We can inject synovial injection, but there's 1 or 2 patients with synovial injection after post-EVR ulcer bleed. They did die of a cerebral embolism. There are a couple of studies from Chile which showed when the ulcer is there, they did a variceal clipping. And I can show you one figure where they did a good variceal clipping and the hemoglobin stops. Then you have now, in 2019, there has been some recommendation of detachable endoloops. The problem with detachable endoloop, if they fall off early, the scabs can be very, very large and the patients can have a large ulcer bleed. And now, even though it's costly, hemospray has also been documented as an endoscopic method to buy some time before you go for a second look endoscopy. If the bleeding is exsanguinating, we can put Sengstaken Blackmore tube, which can prevent the rebleeding. But the problem with Sengstaken tube is they can have aspirations, they can have esophageal perforation and necrosis. There's been a definite role of self-expanding metallic stent in some of these patients. And the first recorded incidence of putting a self-expandable metallic stent was in 2010 from the Spain group, where they put the Elidana stent, and these stents can be put without a radiological or endoscopic help, and these can be kept in place for 2 weeks and later we can remove it, and it has been shown to really help patients with post-EVR ulcer bleeds. In patients who have got as exsanguinated bleeding and with the treatment failure with endoscopic, early tips also has been indicated, and there are some studies especially from the Belvidere group where 5 to 6 patients underwent tips successfully with PTE coated 8 millimeter tip stent, and patients survived. But there are certain incidences where patients after tips died because of the high MEL score. So it is not, before we put tips, it's important we look at the MEL score because incidence of death or encephalopathy can get aggravated if the MEL score is high. And surgical options have been then done. Sometimes surgical options has been done, but there's off late has not been of major use in post-EVR ulcer bleed. So the management could be endoscopic, where we need to do a new band ligation. We can have a cyanoacrylate, variceal clipping. There has been some reports of detachment of hemospray, balloon tamponade and self-expanded metallic stents have been in use. TIPS can be used as an emergency therapy, as a rescue therapy in these patients, especially if the MELD score is not too high. But there are some times when the patients have died before using TIPS. This is where a patient can have a banding, a relook banding. At the same time, in one patient where there was an ulcer, it was closed cleanly by a hemoclip. Something about the TIPS. This is a study which showed early TIPS may improve prognosis in patients at high risk of failure with HB. That is, after post-ulcer bleed in about 22 patients from the Belvitage group, after giving terlipressin when the HVPG did not come down below 20, and some of these patients were put on rescue TIPS, and they found that the treatment failure TIPS was much less than other therapy. 6 months mortality is less, and 1 year mortality is also less when you have put the patient on TIPS. This is a classical another meta-analysis which showed that early TIPS favors a better survival in these patients. Expandable covered stents, other data which shows the coated self-expanding metal stent called esophageal stents. Special introducers allowing placement without endoscopy can be done, and these stents can be removed after 2 weeks with complete healing of esophageal ulcers. And this is a randomized control with uncontrolled study with balloon tamponade and esophageal stent. And we found that the combined endpoint survival of the esophageal was 46%, and 6 weeks survival was better with esophageal stents than balloon tamponade. The study from ILBS has given us excellent algorithm published by Kapil Jamwal, and he has classified, again to repeat, that there are 4 types of ulcers. It is type A, ulcer with spurting; B, ulcer with ooze; ulcer with clot is type C; and ulcer with a clean base type D. So any patient who comes with a post-ileal ulcer bleed, the recommendation is stabilize the patient, emergency endoscopy, and classify the post-endoscopic band ulcer. If the post-ulcer is type A, that is spurter or ooze, you assess the liver disease status, look at the MELD, and look at the child status. If the MELD is less than 24, child is type A and B, we can offer them rescue TIPS, repeat EVL, and probably once they stabilize a liver transplant. If the MELD is more than 24, they suggest a liver transplant. SCMS is possibly the best option for them, because TIPS in this patient can push them into an encephalopathy because of higher MELD and type C and SB2. If the post-endoscopic band ulcer is type C, D, or is it a clot or a pigmented base or a clean base? If the MELD is less than 24 and CTP-AB, we can repeat EVL, glue injection, hemospray, and uncontrolled bleeding with SCMS. If it is more than 24, repeat everything, SM, hemospray, and liver transplant. So this is an algorithm which has been proposed by the ILBS group led by Professor Sareen and Kapil Jamwal's paper. Conclusion: post-banding ulcer bleed not a common complication. It occurs anywhere between 3.6 to 11%. But it's a noteworthy cause of mortality because the mortality is anywhere between 13.5 to 52% in the first 5 days and reaches about 14 to 20% in 6 weeks. Child class C, high MELD score, emergency ligation, presence of HCC, portal vein tumor thrombus, peptic esophageal, bacterial infections are common risk factors. Whenever possible, all of them must be assisted and controlled before prophylactic variceal ligation. Post-banding treatment with PPN supplying seems to be advisable but does not make a difference in the post-ulcer bleed or survival. A new upper GI endoscopy must be realized as early as possible within 12 hours to classify what is the type of type of post-banded ulcer and probably optimize the patient and plan the strategy. TIPS can be considered in case of treatment of failure as a bridge for liver transplant. It has been shown that if you are not able to reduce the HVPG less than 20, a rescue TIPS gets certainly a better survival and can be a bridge to a transplant. The optimal management of this complication still remains uncertain. As I told you, we don't have a definite guidelines, and most of the studies have come as a case control studies on retrospective studies. Thank you very much.
I am not sure whether we are going to have the speakers and panelists on the screen, but I must thank Dr. Rajeev Khanna and Dr. L. Venkatakrishnan for excellent talks on the difficult subjects. Thank you very much. So before I open the discussion to the panelists, can I ask Dr. Rajeev Khanna one question? What do you think is the role of terlipressin octreotide for acute bleed? And what do you think is the role of beta blockers for secondary prophylaxis?
Okay, thanks, Dr. Ashish. About means role of splanchnic vasoconstrictors, we routinely use octreotide for control of variceal bleed in children. So this is as per recommendation for older children, means who are around means in adolescents, 14, 15 years of age or older than that. So we have used terlipressin. And children, there are issues that we have seen in some children. They develop peripheral vasoconstriction and ischemia also. So that is actually a concern with usage of terlipressin. So we stopped using terlipressin and we are okay with usage of octreotide. So octreotide well controls bleed, and if we are doing timely endotherapy, taking the patients for timely endoscopy, so then that actually takes care of the variceal bleed in most of the children. And your second question is about the usage of beta blockers as secondary prophylaxis. So here I can say that it means for all children, what we are using, those who already so we put them on beta blockers, but for primary prophylaxis, it is not routinely recommended. As I have shown the data in one of these slides, that most of the centers worldwide are using some sort of primary prophylaxis, whether it is beta blocker or band ligation or sclerotherapy as prophylactic therapy. But there is no standard practice for usage of no recommendation for use of beta blockers, and there are concerns for uses of beta blockers in younger children, like it can precipitate hypoglycemia, and also beta blockers means like some children have hyperreactive airway disease, so beta blocker can precipitate bronchospasm in children, in young infants where they already have smaller airway. So that is actually a concern. So there is need of trials for beta blockers as primary prophylaxis and also for secondary prophylaxis in children. And we are in the process of conducting and the process of recruiting children for primary prophylaxis for usage of beta blockers in cirrhotic children.
Thank you, Dr. Khanna. One question for Dr. L. Venkatakrishnan. Is there anything during the banding that one can look for to prevent post-tibial ulcer?
If you're able to suck only the varix and do it, maybe the ulcerations are much less. But if you can include sometimes the paravaricial or two ulcers together and band, they feel that there'll be a bigger ulcers, and that could produce probably bigger ulcers and the bleed. Most of the times, this ulcerations occurs when the band falls off much earlier than the typical third or seventh day. So that's what is the problem. But we can carry out only the varix and then do it. Then the size or complication of bleeding is much less.
Anything on number of bands that you would want to put?
See, the number of bands have got no correlation to bleed. But it has always been shown that when you're doing an emergency ligation, you tend to put more bands. When you're putting more bands, and then it is most probably that you can create more ulcers. So only one study has shown about this number of bands in the Mayo Clinic study. It showed when you apply more than 6 bands, and if your interbanding interval is less than 3 weeks, you have more incidence of post-tibial ulcer bleeds.
Thank you, Dr. Elvik. Are the panelists also going to can ask questions?
Hi, this is Dr. Vidyasagar. I've got a question for Dr. Venkatakrishnan. Very nice exposition on the topic, as well as Dr. Rajeev Khanna. Thank you so much. My question is, now we have got midodrine available in India. Is there any role of midodrine in prophylaxis for these ulcer bleeds?
In midodrine?
Yeah.
In preventing this bleed?
Yeah. post-EVL
I have not really come across the use of midodrine. Actually, none of the vasoconstrictors are used as a prophylaxis to prevent the bleed. Even simvastatin, somatostatin, octreotide, or midodrine. I have not seen a literature of any midodrine, but these are also not to be used as a prophylaxis.
Correct.
Post-EVL ulcer bleed. You can use it whenever you encounter a bleed, but not as a prophylaxis to prevent EVL bleed. No, these vasoconstrictors, in fact, they showed much higher bleed when you compare it with proton pump inhibitors.
Okay, thank you.
So last question, sir, and this is from the audience. For Dr. L. Venkatakrishnan, is the risk of post-EVL ulcer bleed more with local rubber bands than the standard Cook band? What is your experience?
Honestly, I don't have experience. I think people who bleed and who have got higher MELD, poor child C, active alcohol abuse, they come much earlier with post-EVL ulcer bleed and higher mortality than the band per se.
Sure, sir.
I don't know about your experience or other panelists' experience with this.
Yeah, I will agree with whatever you say, sir. I think we have had a nice session, sir, and we were running short on time, so I couldn't take a lot of questions. With all your permission, can we wind up now? Thank you, all the speakers and panelists. Thank you.